we are honored to be joined by Dr. Muthana Al-Obaidi, a pediatric rheumatologist from the prestigious Great Ormond Street Hospital in London. Firstly, because of his expert knowledge in pediatric rheumatology, and more importantly, because of the fact that he is proudly an Iraqi-born physician. It is wonderful to see so many of you here today, including guest of honor, Dr. Hussein Habis Al-Hasnawi and Dr. Ziad Tariq, a rheumatologist, well-known rheumatologist here in Babylon, and doctors, pharmacists, and residents. My name is Dr. Ihab Raad. I'm thrilled to be part of this event and to see so many familiar and new faces in the audience. Thank you all for being here. This webinar aims to help pediatricians and residents alike in Babylon keep pace with the medical practice abroad. Over the next hour or so, Dr. Al-Obaidi shall be covering different topics in this field of practice relevant to our needs in Babylon. Your questions have been forwarded to him beforehand, and I hope he has enough time to answer some of these questions. We hope you will find the webinar insightful and networking opportunities valuable and the overall experience enriching.
اوكي يعني انا جدا اتشرفت بيكم. اشكر طبعا دكتور ايهاب، دكتور حسنين، وكل الفريق اللي دكتور عبد الله اللي دز اللينك البارحه، ايضا شكرا جزيلا، وكل الزملاء اللي يعني بعثوا اسئله. قلت له دكتور ايهاب اسئله ممتازه و indicates يعني people are looking after really good going serious cases. يعني راح احاول اغطي as much as possible in terms of a kind of emergencies we deal with. Okay, so we'll be trying to cover emergencies in pediatric rheumatology. The objectives is to learn how to deal with acute scenarios and reality on how the timely, how to pick it up early. Unfortunately, in pediatric rheumatology, so although you think it might be, you think arthritis, but we deal with inflammatory condition. Unfortunately, some of the conditions that we deal with can have mortality rate can go up to 30 to 40%. Which actually you don't see that even in oncological conditions in pediatrics. We'll try to get some background about the diseases that specifically. I'll try to concentrate on conditions that you do see in children more than in adults, and to see how to approach them. You think pediatric rheumatology, everyone is happy and well, children. In fact, we deal, as I said, with lots of children. I have usually when we have trainees, when they finish training, usually our training are quite senior, and we ask them to give feedback. So one of them put that half of the time she spent was trying to stop patients from going to PICU. And then we end up having doctors who are doing PICU come to our department because we deal with various conditions that, some of them, in particular, the lupus, the vasculitis, the MAS ending up on a PICU. What are the issues with pediatric rheumatology? Well, first, you don't have the specialty. You don't have the specialty in Iraq. It's looked after by the adult rheumatologists, which is great. They've been of absolutely great help, and they developed great experience. But there's an issue that children, as we know, are not small adults. There are issues related to development, and changing doses are different. In a pediatric, we change the doses when the child grows up. Also, there are particular conditions like Kawasaki and systemic JIA. We see it more in children rather than actually it's a pediatric type of condition. Then you have the issue of going into puberty and the changes and how to communicate with children and parents. So really, you do need to have a pediatrician dealing with this sort of condition. What's the diagnostic framework? Really, it's similar to pediatric rheumatology is the closest to general pediatrics. Every subspecialty, you have a start and end, gastro, respiratory, you deal with a specific organ. In pediatric rheumatology, there's no start and no end. You deal because you can have the lungs involved, you can have the gut involved, a brain involved, skin, muscle, joint, kidneys, obviously. So every part can be involved. So what's important in terms of the diagnostic framework is start broad. So infection, malignancy, inflammatory, any, and then try to narrow quickly, in particular when you deal with a sick child. Always think about all the systems, all the organs. Think about the red flag. So, are there any red flag that can indicate infection, malignancy, or a serious inflammatory condition? Never dismiss a rare condition. Always consider it because potentially you are doing like Dr. House stuff. So, what do we do in pediatric hematology? We diagnose and manage inflammatory conditions. We have zero tolerance to inflammation because if we leave inflammation, it will leave damage. So I put this as an example. If you leave this car, if you don't control the fire, it will spread, it will destroy. So we have different approaches. I put this on the right. I mean, there are lots of questions, really great questions I received. I call it steroid on the left of the picture, and on the right is to be targeted to how to switch off the inflammation, how to switch off the fire. Like in fire, you have different, depends on what is burning. Same in inflammatory condition. Now, this is the Dr. Yasmin, I think, asked about malignancy and why are we always concerned about malignancy in inflammatory condition. Half of what we do, so although we do rheumatology and we have a big unit and dedicated ward and all of that, but half of what we do is ruling out infection and malignancy. They can present exactly similar. So even so, as an example, the group in the Scandinavia, they reviewed the presentation of hematological malignancy, first presentation. I'm talking about leukemia, all type of leukemia, and lymphoma. I'm not talking about bone tumors. They presented 20% presented with joint condition, joint pain, but actually just under 20% presented with actual arthritis. And some of the patients were treated with methotrexate and steroid as arthritis. So that is, as I said, that came from the hematologist to say that when you have arthritis, you have to think. And I'll give you an example about a patient referred to us as arthritis oligoarticular type that turned out to be malignancy. Infection, always think about infection. Remember, whenever you have systemic inflammatory condition, you have modulated immune system, so you will end up with actually risk for infection. So, and then the infection, as I mean, I remember cases when I was a medical student were diagnosed as, uh, you know, sepsis with disseminated sepsis. But actually, when I look back and think about what we're seeing, it was more of complication of hyper inflammation, and it turned out to be anyway. I mean, usually they have very high mortality rate. But anyway, going back to infection, infection can mimic this. So whether this is sepsis or a hyper-inflammatory process, and the body is starting to have the phagocytosis and eating up the cells and the body. I don't know. You are not. You don't know anyone in the UK would recognize the pictures of those two children. That's Victoria Klimbay and baby Peter. Hassanin can tell you all about it, and actually you can read online about it. It's very heart wrenching. It's really sad. Those children were killed by their parents, and actually in the report of baby Peter, there were multiple fractures missed on the spine, and they criticized in the report the pediatrician to why did they not check the joint because there was a clue. So always, whenever you have a child presented with a story that does not fit the examination, I know in Iraq is not as common in particular because you have the extended family, but I've been hearing story again and again and again about non-accidental injuries. So always think about the late presentation for a significant injury, or if the story does not fit with the presentation, always think about non-accidental injury. Unfortunately, those children were seen so many times by health professionals. They were not saved, both killed by their family and loved ones. So the first case, I think Dr. Yasmin was asking about the malignancy and inflammatory condition. This is a girl referred to us with 10-day history of fever. And the fever was daily and quotidian. Quotidian means the temperature goes up really high, 40, and goes down to normal or below normal. With left ankle arthritis, true arthritis, good going swelling. And she had periarticular tenderness, hepatomegaly, 2 centimeter, and the CRP was sky high, ESR was very high, ferritin was highish, not terribly high, but highish. And the low, all you can see all the lines were low. So low hemoglobin, low white cell count, low platelets. So was referred as arthritis, and I'll tell you a scenario that they potentially can present like this in case of macrophage activation syndrome complicating systemic JIA. But the story did not fit. The markers, the other markers for MAS was not quite fitting. A single joint inflammation, two joint inflammation, three joint inflammation should never give you a very high CRP and very high ESR. They will be slightly raised, but not significantly. Whenever they're high, think, am I dealing with infection? Am I dealing with malignancy? Am I dealing with other condition? I don't know, lupus, so, and this is just part of it, this arthritis. Or am I dealing with a complication? So never oh, like I missed a 20 joint. Never accept a very high ESR and high CRP for a 1 or 2 joint. So because the child has pain, we did X-ray, and the radiologist I remember told me dirty looking bone. I said I've never heard such term. I don't know if they are radiologists. He said dirty looking bone. He said I'm worried about this child. The bone, that's on the X-ray actually. So we decided, okay, that does not fit. So we asked actually for bone marrow aspirate. This sort of scenarios, we always go for bone marrow aspirate. We speak to the hematologist, they assess, anyway, on the day, so she was booked for bone marrow aspirate, and then actually on the day, it was 2 days later, on the day of the bone marrow aspirate, we picked it up anyway on blood film, and you can see the blood film riddled with blast cells. So it was actually it was AML, it was not ALL. Next scenario, also going back to the question about infection. This is a child with juvenile idiopathic arthritis. So there's no temperature and not immune to, never had chickenpox. And in the UK, chickenpox vaccination is not part of the routine immunization, but parents can go and do it privately. Or when we diagnose a patient, we do send them to be vaccinated. This child was neither, not vaccinated, parent didn't want to, and never had chickenpox. So the child was on tocilizumab, which is anti-IL-1, and methotrexate plus prednisolone. Developed vesicular rash and just went into, I mean, it was chickenpox, but then progressed into respiratory failure and was admitted to PICU and was diagnosed actually with varicella zoster pneumonitis. Eventually survived, but always consider when you have a child on immune suppression, infection is your first thing whenever they call you about any infection, any deterioration. What we do normally, if they develop chickenpox, we stop all the medication, we put them on IV acyclovir. If they are, as an example here, on methotrexate and tocilizumab, we put them on IV acyclovir until the no more new vesicles, and then we switch them to oral. And then this is the scenario about that I talked about, which is we see it a lot in our ward. Hopefully, you don't see it as often. This is a 6-year-old girl who's previously fit and well, 7-week history of temperature, which is a quotidian that goes up and down. So that is the temperature chart. So temperature goes up to 40, 41, and then goes down to normal or below normal. So we called it quotidian. And at the same time, with the temperature, the child develop what we call evanescent rash. It's non-specific rash. It's not like you look at the rash and you say, okay, this is systemic type of rash. The rash becomes very pronounced with the temperature. Sometimes it doesn't disappear fully. Sometimes it fully disappears when the temperature goes down. So we call it evanescent rash. And then the child has arthritis as well. Obviously, in this case, you always, the first thing you think about infection is this infection. So we did an extensive, the child also has hepatosplenomegaly, tachypneic and tachycardic, pale and unwell looking. Differential diagnosis, always infection. Always think about infection and treat broadly. This sort of patient, we start them on broad spectrum antibiotics. I know you do the same. And we do blood film. We do ask the hematologist for BMA, and we look for viruses. We've seen that with EBV, with adeno, actually even more. And think about systemic inflammatory condition. Think about lupus, vasculitis. So, as you remember, I said just have broad differential diagnosis and try to narrow it down quickly because this child is really sick. White cell count is very low, neutropenic, thrombocytopenic, anemic. We did a blood film. Actually, we did bone marrow aspirate, and there were no. There was definitely just hyperinflammatory. We didn't see much of macrophages. ESR very high, CRP very high. Fibrinogen, and this is dangerous. Fibrinogen is very low. When the fibrinogen is under one, this child is at risk of bleeding. High AST, high LDA, transaminitis plus high LDH. We did autoimmune, everything was negative. We did extensive infection and was negative. In the middle of it, the child was tachypnic, tachycardic, was developed cardiomegaly, TROP, and proBNP were high, which is an indication of heart muscle involvement. So the diagnosis was systemic juvenile idiopathic arthritis. And these are the criteria. You have fever, you have evanescent rash, you have the fever quotidian, arthritis, you can have serositis, pericarditis. But then that was not all, because if you look at the result, the ferritin was 14,000 and the normal is less than 200. And the repeat blood count, you can see things are going downhill. Neutrophil is going down. So this child, on top of that, is at risk of, they are very neutropenic. And ESR dropped from very high into low. And this is a bad sign. So when you have a child who's really sick and the temperature is not getting better and temperature going from quotidian, like up and down, into constant, and you see the ESR is dropping and the platelet goes down from 700 into 300, this is a bad sign. This is not a good sign. This means there's the macrophage being activated and they started to kind of eat up the body. So what we are dealing is with macrophage activation syndrome, or what we call secondary HLH. Obviously, because we deal with very small children, whenever they are under 1 or 2, always consider is this a primary HLH. So always involve, I don't know who looks after HLH in Babel or in Iraq, whether the immunologist or the hematologist. It's a primary, you just go on a protocol. There's a protocol for the primary HLH. Secondary HLH, rheumatological disorder, is just one. Actually, they account for around 20% of the macrophage activation syndrome caused by inflammatory condition. And the commonest one is always actually infection. We've seen actually, unfortunately, children who died with the MAS complicating EBV and or became very sick with the adenovirus. Malignancy, definitely, we've seen that. I showed you the case that was like in the middle of MAS. We've seen it in leukemia, actually, in AML. And actually, we've seen it once with a solid tumor. It was very rare myosarcoma complicated by MS. The reason why I know about it because we were called and then tissue biopsy diagnosed the case. As I said, if they are young, consider the genetics. These are the features of the what you know the of macrophage activation syndrome. I have to say, these features, if you are at this stage, the child is in a big trouble. So if there's constant fever, hepatosplenomegaly, hemorrhages, central nervous system dysfunction, here the mortality rate goes up to 30 to 50%. So the idea, I mean, the big message is be ahead of it. Don't wait for all the cytopenia. So just look, you don't wait for the platelet to be 50. If the platelet was 600 and the child is not getting better clinically and it drops to 250, step in. This does not mean you have to wait until it's under 100 to call it MAS. If look at the trend of the liver function and look at the trend of the fibrinogen and rising D dimers. Fibrinogen act really because it's terrible. You know, when it happens, I don't know. I hope you haven't seen them. Unfortunately, we've seen them. They can just bleed to death and you can't control it. The way we describe it, as if the child falls off a cliff and you can't, you no matter how much you push with treatment, you can't save them. So the idea, really, the big message is think about it, and then look at the trend. So always repeat the blood. In this sort of cases, sometimes we repeated the blood every 8 hours. You don't need, you do the full blood count. You look at the ferritin, you look at the clotting, and you look at the liver enzyme, the transaminases. Because you have to step in. If it's established and they develop hemorrhage and CNS involvement, it becomes so difficult to save the child. These are the genetic defect associated causing primary HLH. I mean, our colleague, the hematologist or immunologist usually deal with them. But we do send perforin, and we, in particular, in the young ones, actually anyone who's actually any age, we check the perforin and granulase assay, and we check the SAP and the SIAP. But as I said, I mean, if they're young, and for me, it doesn't matter, to be honest with you. If they need treatment, you just get on with treatment. If they're very young, you get a friend, hematologist or immunologist. Now, what we do in terms of the MAS, I mean, this is a good. So this is the Printo diagnostic criteria for MAS in systemic JIA. We use it now in all. I mean, in the trial, like as an example in the emapimab. That's what we relied on. So what we have, because we have electronic system, so we have what we call smart phrase. We just put any child with systemic JIA. We put this. So every day in the ward round, we put. Is the fever still there? Is the ferritin more than 684? And what's the platelet count? What's the AST? What's the triglyceride? What's the fibrinogen? As you see, because it's a different unit, we use different units for fibrinogen, but you can always, change it. So if it's MAS, just don't relax. If the child, even until you get into the child does not fit partial MAS, because the idea, as I said, is just to watch them closely to stop them from going into established MAS. There are some monogenic causes of MAS. We started to have genetic conditions. They present with MAS. Genetics, these are the papers. I don't know if people want to look at them. They are, the old paper. What you need to remember, treatment is the same for any sick child. Treatment is A, B, C, D, and supportive. Always supportive. This is the primary treatment. So do they need oxygen? Do they need to be ventilated? Do actually product, be ahead of, always have a hematologist friend and be ahead of the deranged clotting. I promise you, it's so traumatic to watch them when they go into hemorrhages and clotting failure. There were times where we gave FFP, cryo, and there were times actually we just gave fibrinogen. It was difficult for us to access it, but actually we had children when their fibrinogen level was like next to zero. So we were just giving them fibrinogen, blood transfusion, platelet transfusion. This is different. Remember, in things with autoimmune kind of thrombocytopenia, given a platelet that they get consumed. Here is the bone marrow, they kind of end up with the consumption. Then a treatment. So I think this is very important slide. This is just I'm just showing you the evidence available. The In reality, the only trial we have is for the emapilumab. We've done them in our ward actually. With anti-gamma interferon. But the first thing is steroid. Steroid we hit hard, 30 milligram per kilo with maximum of 1 gram. We give for 3 days. I gave sometimes for more than 3 days, 5 days, 6 days. I'm talking about patients who were so sick and they were on like 4 agents. Cyclosporin is good. Cyclosporin is good, although remember they can have CNS involvement and it can cause nephrotoxicity and encephalopathy. But actually, you can access it in Iraq, and you start with a low dose and then you increase it. I go straight away for the IV when the child is sick. Don't bother with the oral, unless obviously it's not. I'm sure it's available, and cyclosporin is not a very expensive medicine, but actually it is a good medicine that we introduce. I introduce early in MAS if I'm worried. Obviously, I've seen cases of press or toxicity from the cyclosporin, but really never dismiss cyclosporin. It's good because for us, first line we use is anakinra, and I'm not sure how much it's available. Forget about the 1 to 4 milligram per kilo. We never actually give one. These are the trials about 1 to 4. But now actually we give up to 20 milligram per kilo. I start with 6 milligram, and we know the evidence. If you give it when they are sick, we give it continuous infusion, and we go up to 12 milligram. The Americans go up to 20 milligram per kilo. Anakinra is just we feel so comfortable about using it, and sometimes when we are not sure, we use anakinra because the half-life is very short. It's 24 hours, and the evidence for infection, I mean, it seems to be fairly safe. There's a trial in Brazil where they gave anakinra to sick patient on PICU with no clear diagnosis, and actually they had good result for around 60% of them. None of them had complication. I mean, the other 40% they found other causes, but none of them had complication with infection. And then we have the anti-gamma interferon. This is the new kid on the block. And it was used in a primary HLH. It was not as good in a primary HLH as in the secondary HLH, which is macrophage activation syndrome. This is given as IV. This is just during the period of the child being unwell. IVIG, I wouldn't bother because if you read about it, the Tristano who reported its use, actually all the time it was used with a steroid. So we don't think it was, I mean, IVIG, it helps if you are worried about infection, obviously, and you are still waiting to get the biopsy or the culture, etc. But actually, IVIG, it's not a treatment for MAS. And then they may need to get the hematologist involved to give etoposide. I'm talking even about MAS. We give etoposide, a plasma exchange on PICU, and a bone marrow transplant. So that is the first one. So just to consider it, I think the first thing is to think about it. Is this macrophage activation syndrome? And then you monitor closely. I think lots of you kind of dealt with similar story during the COVID. Because it was, I mean, not exactly the same, but actually they were developing sort of similar pattern. But any infection can give you this. So COVID, remember, is an infection and it gets complicated, and we called it PIMS-TS, and the American called it something else. And as you remember, you all felt comfortable giving lots of steroid and IVIG helped actually in the post-COVID. But actually, any infection, think about is it being complicated by MAS? Lupus, is this complicated by MAS? And systemic JIA is the usual culprit. But remember, and it's relevant to you, 20% only of the macrophage activation syndrome are related to infection. Rest is actually infection and malignancy. Now, next one, who asked me about, I'm trying to remember who asked me about the HSP and one of our Sudanese colleagues. Dr. I think Salma.
Dr. Salma, yes.
Yeah, Dr. Salma. So I'll go through this story. This is a child presented. I'm using the picture because we published the case anyway. So this child presented with typical HSP rash and was okay, assessed in the A&E. Parents were told to watch, the GP to follow up with the blood pressure and urine dipstick. Child was okay, and then 2 weeks later presented with a history of high temperature and developed episode of rectal bleeding. So he was referred to, if this is the hospital close to us and there's a pediatric department, so was referred to the pediatric surgeon in our hospital. I had a call 3:30 in the morning because our trainee who was covering one of our ex-trainees covering the surgical ward told me the story, and she said, "Oh, I remember you did something about HSP and you have to treat with steroid for rectal bleeding." Anyway, heard the story. Basically, you can see there's cutaneous necrosis, and the child arrived to the hospital very unwell, very tachypneic, unwell looking. We said, if you're comfortable, this is HSP. They sent me the pictures. We gave steroid, methylprednisolone, straight away. And then we did a chest X-ray. Okay, what's going on? Is this an infection? So the child on, antibiotics to cover for infection. The child stopped having rectal bleeding. That's the win. But what was happening, the child was becoming more tachypneic, needing more oxygen, and the hemoglobin was dropping. So we thought, okay, the child is bleeding somewhere, but there's no PR bleeding. Creatinine started creeping up and then went to 200, and I don't know what's the normal range for you, but 200 is very high. The child was intubated. So because the child was deteriorating, the child was meant to go for renal biopsy to confirm the diagnosis, because we were worried, is this actually HSP or are we dealing with necrotizing type of vasculitis like polyarteritis nodosa or any type, because that will help us in terms of the long term. But the child was deteriorating. The child was intubated. They put the tube and the blood gushed out of the tube. The child was difficult to ventilate, required high oscillation. You can see the blood. It was like proper pulmonary hemorrhage. You can see the necrotic skin lesions. We did a biopsy, and it was IgA vasculitis with IgA deposits. So how did we treat the child? Methylprednisolone, plasmapheresis, cyclophosphamide, lots of blood transfusion, antibiotics, furosemide, and then that's the beauty of looking after children. I saw the child actually last Thursday looking fantastic off all medications. After cyclophosphamide, we kept the child on MMF and came off MMF 2 years ago. Absolutely fine. Obviously, regular follow-up. So now what we call it, as you know, we call it IgA vasculitis. We stop calling it HSP. You can see always when you suspect, when it's really bad and you want to give steroid, always do a biopsy. And with the biopsy, send for two things: histopathology, because you're expecting leukocytoclastic vasculitis, but also look for IgA deposit. So ask for the histopathology and the immunoglobulin deposit. I don't know why these slides are moving on their own. Um, so, so always histopathology and IgA deposit. The IgA nephropathy. So you have focal and segmental proliferative glomerulitis. So 20 to 60% of IgA nephropathy patients, depending on the definition, they will develop the nephritis. Usually they present few days and few weeks after presentation. Can occur up to 2 months, rarely. So that goes back to the question, rarely for um, more than 2 months. There are case reports of them happening very much later. Always the question, have they always had it and it was missed because there was no follow-up? There's a pathway to follow up the patient with IgA vasculitis. I don't know what's happened. Why is it moving? So from not moving into like moving. Okay, so that you have now the IgA vasculitis nephritis 2024 IPNA clinical practice recommendation. So, Dr. Salma, you can have a look, well, all of you, at the recommendation for the diagnosis and management of children with IgA nephropathy, and you can see if you watch them, if there's no if initially there was some macroscopic hematuria, but no proteinuria, you follow them up for 12 months. Otherwise, it's a long-term follow-up. And you can see the indication for so all of them will need kidney biopsy. Some of the parents now following the new guidelines actually get surprised to why we want to biopsy because the child is better, and you show them the evidence that there's still high protein in urine. So although the child doesn't have the rash and they don't have like nephrotic features, but actually it helps you in terms of the long term looking after the children and uh, how to manage them. What are the indications? So we always get this call, shall I give steroid? So what are the indications for steroid non-renal IgA vasculitis? So this is the non-renal. So if there's a severe hemorrhagic edema affecting the face or the scrotum, if there's severe bullous HSP, or definitely if there are necrosis in the skin, so whether there's a bullous or necrosis, then you do give a steroid. If there's testicular involvement, if there's a severe GI, whether severe pain or bleeding, and if there's obviously pulmonary hemorrhage, vasculitis, pancreatitis, these are the indication for steroid. Next case, this is a quick one because it's an interesting one. This 6-year-old referred to rheumatology because he has transient infantile neutropenia and there's history of hepatosplenomegaly, long-standing livido. The type of livido is livido racemosa, not livido reticularis. They are different. So livido racemosa. Inflammatory markers were not impressive. ESR slightly raised. And the child was seen, was like, okay, most likely this is nothing. Let's do, because of the neutropenia, let's do genetic testing. The child came, actually, it was a clinic appointment. It was in New Year's, no, Christmas Eve. And a 24-hour history of testicular pain. And we admitted the child. On the same day, we received the genetic testing that the child has data to. Anyway, going back, so we did ultrasound scan. There was ischemia, testicular ischemia. So it was explored. As I said, because on the same day we had the result of the data to, so the biopsy was showing vasculitis. The biopsy was showing vasculitic changes. As it was the same day, he was diagnosed to have data 2, and it was homozygous. We started methylprednisolone. So what they did, the urologist, opened it, explored the scrotum. She kept she did not, we did not remove the testicle. Methylprednisolone, anti-TNF started. So we pulsed with methylprednisolone, and then we started 3 days later with the adalimumab. And the pain resolved actually after the first dose of methylprednisolone. The swelling came down, and then actually they repeated the scan, very good perfusion. So they just stitched it back, and there was no issue. And then he remained well. This is, just to consider a genetic condition, and as an example, in this case, use anti-TNF. I'm hoping in the future we can have a talk about auto-inflammatory condition, and we cover more inflammatory condition. This is a quick one about. This is a quick one about. Um, Juvenile dermatomyositis. And the reason why I want to bring it up, because in particular, there are type of juvenile dermatomyositis that is MDA5. We had, unfortunately, around 3 children died from a severe progressive interstitial lung disease. They were all referred to us. They were referred from somewhere else, and we saw them on PICU, and they were very sick. And the other one was diagnosed on admission on PICU. And when the intensivist checked the pattern of rash, called us to say, okay, can you come? Because that doesn't fit with infection. And there are some rashes, and it turned out to be MDA5 type of myopathy. As I said, consider interstitial lung disease. I'm hoping in the future to talk specifically about interstitial lung disease. And then the next disease that we see it in children rather than adult is Kawasaki. So Kawasaki, we have the HAA diagnostic criteria. You see Kawasaki more than I do. We see the complicated Kawasaki. So when I say complicated, we see this type of Kawasaki. So this child, we wanted to do we thought this is lymphadenopathy, and it turned out to be aneurysm. And you can see this child with the severe necrotic vasculitic changes. Remember, it's a type of vasculitis, and I'm hoping in the future also to talk specifically about childhood onset vasculitis. So you need fever and for 5 or more days, and 4 of the 5 criteria. As you can see the criteria: the oropharyngeal changes, edema, peripheral edema, and peeling, non-purulent conjunctivitis, the rash, and the cervical lymphadenopathy. In Kawasaki, if they have BCG vaccine, you can see it becomes pronounced. Now, what are the complications? So the main issue about Kawasaki, and I hope I won't confuse you because we've just finished the trial called KD-CAP. We led the trial, it's pan-European trial. The main issue with Kawasaki is the coronary artery disease, because everything else you manage, they settle down and you treat them and they get better. Even by the way, some of them do develop macrophage activation syndrome. But the issue is the coronary complication. So what we thought we knew, coronary artery aneurysm, these are like all studies available everywhere. It occurs in around 25-30% of untreated cases. IVIG and aspirin reduces this to 4%, IVIG resistant in around 20%, and the risk of coronary artery aneurysm is 30%. So the prognosis for Kawasaki is entirely dependent on coronary sequelae. Okay, that's what we thought we know. The other thing, and this is, you need to have can you see, we deal with all specialties. So we have friends from all specialties, and we did the trial actually with the cardiologist. So the coronary artery, dependent on severity of coronary artery, the Z score, your cardiologist will tell you what Z score is. So if the Z score less than 10 and the dimension of the aneurysm is less than 8 millimeter, then you have 1% chance of having a coronary artery event. What is event? So either you have thrombosis, myocardial infarction, stenosis, ischemia, or even death. And then if you have the score, the Z score, more than 10 or more, and the dimension is more than 8, 50% chance you will have an event, which is myocardial infarction or thrombosis or even death. Now, what do we know? We did in the UK through the BPSU, so all the pediatricians in the country will receive a weekly asking them, have you seen a Kawasaki? And what was the outcome? And we found out, although the studies show 4% is risk of coronary artery aneurysm if you give IVIG, actually, in our patient, we found that it's 20% they develop coronary artery aneurysm even with IVIG. And it's worse if you are under 1 year, and this is the main message about Kawasaki, really. Under 1 year with Kawasaki, be aggressive with treatment, IVIG and steroid if needed, but be and watch them long term. If you have Kawasaki under 1 year, the chance of coronary artery aneurysm 40%. Send them if not only obviously at the diagnosis, but later on, a few weeks later, to make sure there's no coronary artery aneurysm. And the Swedes saying actually 16%. And then the Russians said, oh, actually 30% of our patients develop aneurysm even with IVIG. And the Germans, oh, they say, oh, actually 40%. So we felt there's an urgent need for better treatment. So we have the KD-CAP hypothesis. KD-CAP is Kawasaki coronary artery aneurysm prevention. The hypothesis was if you give corticosteroid upfront with the IVIG and aspirin, the risk of coronary artery aneurysm. This is the hypothesis. That's what we thought will be. And to determine the efficacy and safety of the steroid as a treatment, upfront treatment for KD-CAP. And then this is basically the trial. I'm not going to, so it's divided into experimental group, which is you give steroid, and the other group is you just use IVIG, and then you add a steroid if they are not responding. And these are the countries contributed. And look what we found. So we realized actually steroid had no effect on coronary artery aneurysm. So the experimental group, the one who received steroid, had 1/4 had, I mean, both of them had 1/4 of coronary artery aneurysm. And even worse, if you are under 1 year, it around half of them develop coronary artery aneurysm. Saying that steroid seems to be still good. In terms of they needed less IVIG, so they did not need a second dose of IVIG. And so around 40%, the 40% of the control who are only on IVIG needed second dose of IVIG, while in the under 20% of the steroid group needed second dose of IVIG. So if you think about health economics, you don't need more IVIG. Then 30% of the control group needed longer admission and needed steroid, while only 16% needed longer admission. We are doing health economics analysis, so it will be published. It's being submitted for the press in Helsinki. So yeah, you will hear more about it. Funnily enough, not even the time to normalize CRP between the two, but definitely it seems the one who received steroid had shorter admission to the hospital. And we are still looking at the steroid toxicity to see if it's stopped again. So prednisolone did not demonstrate any effect on coronary artery aneurysm. Does not mean you stop giving steroid, because it helped in the state. What other treatment you give for Kawasaki? So we do give anti-TNF in infliximab. And so these are the other therapies. So Hamada published the cyclosporin for Kawasaki. And as we know, actually, we use it often in resistant cases. Infliximab, remember, it's a vasculitis. And then anakinra. Anakinra, actually, there's a protocol. If you look at the second paper, Compo made a protocol because you don't use it long term, and we use it more with the when they develop macrophage activation syndrome with the Kawasaki. Actually, we have used anakinra. We use mostly anakinra and well, actually, we use all of them: cyclosporin, anakinra, and infliximab. And Akinra, as you know, I think it's tolerate. I think it's available in Iraq now, right? And Akinra is available now, right?
Not available, doctor.
Yeah.
It's not available, no.
Oh, not available. I heard there's like a limited number of anakinra. Anyway, I don't know how you're managing without it. In particular, you have so many autoinflammatory condition. Uh, what we know about the anakinra IV dosing in the acute phase is better sustained if you give it every 8 to 12 hours. Now, in terms of the there's American Heart Association guidelines 2024 on update on diagnosis and management. It's always good to refer to it. And also it goes back to the same message. Children under 1 year, and here they put under 6 months, they are really at risk of developing complications. This is the, I talked about the Z score. This is the update on diagnosis and management of Kawasaki, which is a scientific statement from the American Heart Association. It's a really good document, to refer to. You can have a printout and put it, for your juniors to have a look at it. Lifetime cardiovascular management of patients with previous Kawasaki disease. There's actually now they are provided here with a card, which maybe that goes back to the same question about HSP. Will we need such thing for children if we have more evidence of people develop nephropathy later on in life? But in Kawasaki, we don't have, such a guideline. But for Kawasaki, now they carry a card to show that they had Kawasaki at some point in their life for the long-term cardiovascular condition. I think I'm just going to mention briefly the some of the condition that we see. So ANCA-associated vasculitis. I'm hoping, as I said, in the future we can dedicate a whole talk for vasculitis in children. You can see here upper airway. You can see how the nasal bridge fell. Usually they present with epistaxis and nasal discharge. They can have a lower airway, lungs involvement, and they can have vasculitis, arthritis, CNS, and obviously the renal involvement. Eosinophilic GPA is rare, but our experience with the eosinophilic GPA may overlap with the primary hypereosinophilic syndrome in children. Asthma in 3/4 of them, mostly pulmonary and skin involvement. Mortality in our cases was 15%, and cardiomyopathy significantly associated the mortality risk. Here, if you see, this is a post-mortem, a patient that we gave everything, actually plasmapheresis, cyclophosphamide, rituximab, steroid, and then so everything peripherally was normal. Anyway, because of the heart failure, and they needed heart and lung transplant. So this is the biopsy showed, even though peripherally there was nothing, the heart was riddled with eosinophils. Takayasu arthritis, this is also our experience. Hypertension was the most common presentation. They had treated mostly with steroid, methotrexate, tocilizumab, and anti-TNF. Mortality rate was 30%. It's bad news if the presentation under the age of 5 years, high mortality rate. So, in summary, in medicine as in life, the key to solving the puzzle is to know which question to ask. Be systematic, think from head to toe. try to prioritize the red flags, collaborate, always work with other colleagues, and always actually listen to the parent and the nurse looking after the child. They will know if the child is deteriorating and they will tell you. Stay curious, consider rare conditions. Inflammatory condition can have a broad presentation, potentially high morbidity and mortality if no timely intervention. Consider side effect of medication, whether bone marrow suppression, infection. Always consider infection and malignancy, and whatever the etiology, always start with ABCD. I think that's it. Thank you very much. I have 1 minute to go through some questions.
We have one question for that 1 minute from Dr. Angham. What's your question, Dr. Angham?
Regarding non-IgA vasculitis, non-renal IgA vasculitis.
Sorry.
Regarding the treatment of...
Let me just sorry, I'm going deaf now. Let me just make it louder. So in IgA nephropathy, is that your question about IgA nephropathy?
Indication of steroid in non-renal IgA vasculitis.
What are the indication, you said?
Yes.
What are the indication of steroid in non-renal IgA vasculitis?
Yeah.
Okay, so if you have scrotal and scalp and face edema, if you have testicular involvement, if you have GI, gastrointestinal, well, severe abdominal pain and rectal bleeding, if you have severe skin involvement, i.e., either some necrotic lesions, you don't have to have necrosis of the whole leg, but if you see necrotic lesion or bullous type, so even if you see like boluses, then this is an indication of steroid. Also, when there's like you would have, if there's CNS vasculitis, if there's a bleeding, pulmonary bleeding, all of these are indication for steroid.
البريزينون يعني هون كيجي or ميثيل بريزينون.
Which one?
I'm really sorry, I can't hear. Is your question what sort of steroid you give? Sorry, is your question what sort of steroid you give and what dose? I can't hear. Maybe you can type it in the chat. I can't hear. I'm really sorry. But if about the dose, you start with 2 milligram per kilo and you wean it down over 8 weeks.
Yes, so I was asking about the sort of steroid. What sort of steroid to use?
Yeah, prednisolone. Prednisolone. If the child is sick, give me prednisolone. If the child is sick, they're lying down covered with rash and there's a GI bleeding, then you give me prednisolone, 10 to 30 milligram per kilo, 3 doses, and then switch them to 2 milligram per kilo. And then you wean down over 8 weeks.
Again.
I'm sorry, Dr. Ihab, if you can, you tell me.
بس رجع الهوست رجع الهوست حتى نسوي ميوت. عاد شلون مثلنا؟
I don't know. Shall I go through the question?
Can you hear me, Dr. مثلنا؟
بس هيرجع
لا
يا صوتي بالله
شو تقول شيء؟ unmute دكتور مثلنا unmute. Okay, can you hear me? Dr. Ammar has a question.
السلام عليكم دكتور مثنى.
عليكم السلام عليكم دكتور عمار.
كان عن محاضرة رائعة. I have one question. In terms of sick child, how can we exclude infection with confidence and give immunosuppressive treatment?
So the question, how can we exclude infection?
Yes.
Oh, you just try your best. So the way we do it, we take a blood culture, we take urine for MCNS and culture, we take MPA and throat swab, we do virology, we go straight away for PCRs, specifically EBV, CMV, and adenovirus. So for us, we target our population. I guess in your case, so as an example, I don't normally check for brucellosis or typhoid. But in your case, depending on what you have that is common in your area, when I have a sick child and it's unusual presentation and I don't feel this is inflammatory, I get actually the infectious disease. So they go and dig, think about history of travel, history of contact with the tuberculosis. I was involved in case referred to me as oligo-JIA. And then we did quantiferon TB gold and it was positive. We did biopsy, was negative, and then we sorry, I was distracted by a question. And then it turned out to be we said we referred to the ID, treated for TB for 6 months, and then they sent back to us. Arthritis came back after finishing anti-TB. They said, that's it, treat the arthritis. I booked her to come for joint injection. She developed miliary TB the day before actually the injection. So you just go, you try your best. You try your best. You don't wait for the child to die while you're hunting for infection. We give a broad spectrum antibiotics while we're thinking, but as an example, in MAS cases, they are challenging because every 8 hours count. So what we do, we go straight away, all guns out. We do the broad infectious screen. We get the hematologist to consider BMA. And then even before waiting for the result, unless we're worried about fungal infection or, I mean, fungal infection, you have to have like something really wrong with your immune system to have it. Whether fungal or TB, we start steroid while we're waiting for the bone marrow aspirate result, etc. You try your best, but you can't, just if you can't, you can't.
Thank you, Dr. Muthana. We have another question from an adult rheumatologist, well known here in Babylon. He's called Dr. Ziad Tariq. He's sitting beside me, and he has a question for you.
Hello, Dr. Muthana.
Hello, Dr. Ziad.
Thank you for your nice presentation, your nice lecture.
Pleasure.
Indeed, I want to ask you about patient with JIA having full remission, when to stop the biological therapy. This is the first question. The second question, can we depend on musculoskeletal ultrasound to say that this patient having subclinical synovitis or enthesitis to stop or to continue this biological therapy? Thank you.
Yes. Okay, so this is very challenging. We just started. Now, there's a trial about withdrawing biologics in uveitis, and we are in the process of having a trial on stopping, how to stop. It's very easy to start. What do we know? If you stop the treatment, that was from the methotrexate trial, by the way, this is very old. If you stop it within under 1 year, then the risk is very high. In terms of the biologics, there's no specific protocol on how to stop it. What do we know? What do we do now? We want minimum 2, ideally 3 years full remission. We don't normally, this is the day-to-day practice. We don't go and scan the joint routinely to look for subclinical synovitis. I know some of my colleagues want to do that, because we are looking at specific markers. We used to do the MRP, which is the calprotectin in the blood. I don't find it very helpful. I'm sure, I don't know whether you've seen the from our center and from the Germans to look at the MRP to guide you when you, at some point, we were doing it. So if the MRP more than 15,000, we say we will not stop treatment, even though the child is in a clinical remission, and will wait. Personally, I stopped doing it. Practically, the way we do it, 2 to 3 years of no inflammation. We start weaning down the methotrexate slowly. And then the biologics, so etanercept, instead of every week, you give it every 2 weeks for 3 months, and then you stop it. We tell the parent, we counsel them, and we watch them closely. We tell them there's a risk 40 to 60% of it coming back, and then we'll see. We don't know which way you would go. Obviously, you think if the presentation was severe with like 8, 9, 10 joints, we are more careful in terms of monitoring. The most important thing, though, I think, is the children who had initial presentation treated with methotrexate and biologics were added, is when you stop them, make sure that you watch the eyes carefully until the age of 12. Because we've seen children, I had a child actually, or I still have her, methotrexate and etanercept, and was so good. Early presentation, never had uveitis, and it was etanercept, not even adalimumab, to say that helps. When we stopped treatment, she never had a problem with her joint. She developed severe uveitis, and we had to actually give her now adalimumab. So bottom line, 2 to 3 years with absolute remission. If you have any clinical concern, do scans. But I don't normally do it. One of my colleagues wants to start doing it in the clinic, so to help her, it's going to be a pilot study.
Thank you, Dr.
But there's a trial coming.
Thank you. We have another question from Dr. Bashir. He's a pediatrician here in the hospital.
Hello, Dr. Bashir.
Hello, Doctor. Thank you for this wonderful presentation.
Oh, you're very kind. Thank you. My pleasure.
I would like to ask in which state you refer such, since these diseases are chronic disease and the patient, our pediatric patient complaining from the psychological symptoms, in which state you refer this patient to the psychological support or social worker? In which state, please?
Yeah. So, we have actually one of our ex-nurses who's become advanced nurse practitioner and now nurse consultant, and she's got her PhD specifically on this. What evidence do we have, and what practically do we have? Evidence we have, a patient, as an example, with juvenile dermatomyositis, they all present with some psychological symptoms, low mood. Patient with any potential CNS involvement, in particular CNS lupus, we all refer to neuropsychiatric lupus to assess the, how they're going to do at school and whether it's affected them. In reality, any child who is diagnosed with a lifelong condition, we do ask this question because some children are okay with it. You just like, give me the medicine and I don't want to talk about it. Some of them get hit really hard. I think every child and parent need a counseling, not necessarily a referral to the psychiatrist, but we do refer to the psychologist, and the psychologist will do the assessment. Any child who is sick in the hospital, we offer them psychology input. The psychologist, very rarely we refer to the psychiatrist. The psychiatrist we refer when there's like, usually with the CNS and the vasculitis complication when they develop proper psychiatric symptoms. But in reality, the evidence is showing more and more that they get hit really hard, not only the child, but the adult. The other thing is, as pediatrician, usually you diagnose a child at the age of 2, and then at the age of 8, they stop taking medicine because they don't know what's going on. So actually target this sort of children as well. If you can get an access to counseling or a psychologist that can streamline those children, would be really good. And now we have a study, an ongoing study in the outpatient. We have this nurse consultant who screen all patients.
Actually, in one of the morning reports here in Babylon, Dr. Ammar has special interest in familial Mediterranean fever, and he mentioned that he read a topic that 1 in 5 persons here in the Middle East has a propensity to develop familial Mediterranean fever. What was your question, Dr. Ammar, about this?
Yes, Dr. يعني nursing textbook يعني mentioned that 1 in 5 person of the Middle East and Turkish ancestors have the potential to develop familial recurrent fever. In our local practice, we see always patients complaining from recurrent fever and recurrent abdominal pain. What's the diagnostic criteria that can be put to diagnose such disease?
And may I add, what if the child is colchicine resistant?
Yes. Okay. So two questions. So there are diagnostic criteria for familial Mediterranean fever, and I can do a whole talk. There's the Tel Hashimo, and then the other. Well, the newer one I think is better because I prefer to Tel Hashimo. So it's there are diagnostic criteria, but the really diagnosis is genetic testing. You have to have a good geneticist because lots of us have some of the variant. Having a variant does not mean that you have familial Mediterranean fever. You have to have a pathogenic variant and you have to fit the criteria. The question about colchicine, in general, actually, when we looked at them, they all should respond to colchicine. It's a really good medicine. The one who don't respond, usually one of two. The commonest cause is they are not taking it. Really, most likely they are not taking it. The second thing is because it gives them abdominal pain. What do we do? Sometimes at the start of colchicine, we say, okay, if you develop this sort of symptoms with colchicine, go on a dairy-free diet. So you just exclude milk, cheese, butter completely for a few months. Tell them, don't worry, it's not going to be lifelong. It's just for a few months until you get over it, and then it will be fine. You can introduce it and it's okay. So these are the usual story. They are non-compliant. In our cases, actually, the next step is we give anakinra. Anakinra, obviously, it's not a nice medicine. It's given daily. And then if you want to give it to them long term, not many people. I mean, I know it's not available anyway, but it's a daily. The other medicine that you can give, which is also it's very expensive, and but we are commissioned to use it if we show evidence. Actually, this is FMF. Is canakinumab. Canakinumab as an injection given every 4 weeks, but. I know because I have Egyptian colleagues, they told me they have lots of patient coming to them, say this is FMF, and actually no documentation of actual fever. And when they reviewed some of them, they were labeled wrongly as FMF. Turned out to be they were just having like intercurrent childhood infection and they have a bit of abdominal pain. And the parents read about FMF and they decided this is FMF. So they really have to fit the criteria. But as I said, really, colchicine is a good medicine, is cheap and fairly safe, in particular in children. And I do blood actually not that often on the ones who are on colchicine.
Dr. Muthana, we have a question from an online listener, Ragad, I think. Doctor, please, what are the clinical differences between Kawasaki and MISC?
Yes, so with the, if you are not sure, just do the COVID screen. I mean, to be honest, we now even stopped checking it, but recently we had one. Kawasaki has specific diagnostic criteria. So you have the temperature 5 or more days. You have the red, tongue and lips, cracked lips. You have non-purulent conjunctivitis, so you have red eyes with no discharge. You have the lymphadenopathy, and you have the fingers and toes and feet edema, and later on they develop peeling of the skin. So the presentation of Kawasaki is very specific. I mean, you're gonna give IVIG for the Kawasaki and aspirin. With the MIS, or we call it PIMS-TS, it's usually it's temperature, rash maybe. They don't have the features of Kawasaki.
Dr. Muthana, the final question is from a veteran pediatrician, is a very well-known person, very kind and very eminent pediatrician from Hindiya, Kuwait. He's called Dr. Hussein Habis Al-Hasnawi. Yes, anyone has a question for you.
شكرا دكتور محمد. عاشت ايدك
شكرا لكم.
عاشت ايدك يرحم والديك على المحاضرة الجميلة. I have one question. Please, why cases of rheumatic fever decreased number in Iraq and world, I think in the world also. This is because of genetic change or something else? Because we previously see many cases of rheumatic fever. Now, little number of that. Thank you.
Thank you very much. I don't know. There are theories. In the past, we used to say about streptococcal infection and the availability of the antibiotics, and people started to use. These are just theory. The honest answer, no one knows. I haven't seen, I've seen 2 or 3 cases here in the UK. One of them, actually, I reported it. It was referred as JIA, and the child was coming from a different country. I think is the hygiene and the early introduction of antibiotics, or something environmental. We don't know, because even in places like Australia, as an example, it used to be common with the Aboriginals. Even within that population, is coming down. We don't know. When to use colchicine in PFAPA?
Yes, this is from Dr.
Yeah.
Christian, from
Yes.
the pediatrician, yes.
Usually, I plan it with the, so if they need a steroid twice a month, I worry about the side effect of the steroid. So the PFAPA is a non-genetic periodic fever, and they present with aphthous ulcer and lymphadenopathy and fever, and the child is well in between. Sometimes you give steroid for 1 to 2 days to reduce the fever, and the question, when do you switch to colchicine? If you are needing steroid so often, or if a child needing lots of days off school, or if the parents don't want to give steroid. Usually, if they don't give steroid, they don't want to give colchicine. We give colchicine. I worry if they are having it every 2 weeks. I bring them to confirm this is actually fever, and they actually have the other features. So if they need it frequently, I give them colchicine. Or if parents are reluctant to give a steroid, I give colchicine. But if it's once a month for 1 day, I think is okay.
Thank you, Dr. Muthana. Thank you for an excellent presentation, and thank you for sharing your expertise. The political situation is now tense, but these webinars help to bring us together, even at times of hardship. So thank you very much for your kind.
والله my absolute pleasure. وإن شاء الله يا ربي الله يسهل، وإن شاء الله يعني إن شاء الله نسمع أخبار زينة.
إن شاء الله.
It's been my honor. يعني I'm pediatrician. Sorry يعني Dr. Matos is here, but I'm primarily a pediatrician. It's always nice to be with pediatricians.
Thank you very much once again.